Hello everyone. I hope that you all are doing fine. So we will start with this topic today, which is the corticosteroid, and we will discuss here what management modifications you may need to do when you are doing any treatment in patient who are taking corticosteroid. Okay, so these are the drugs that patient might be taking or usually taking as a replacement doses for adrenal insufficiency disorders. They are used at therapeutic doses in the management of inflammatory and immune disorders such as arthritis or any skin related condition or even asthma. And at therapeutic doses only, they have the potency to suppress the immune system. So that is the cause why there are so many consequences of ill effect that this drug can do, because this has direct side effect that it lowers down your immune system. The long-term use of therapeutic doses of corticosteroids can cause adrenocortical suppression and subsequent dependence on exogenous corticosteroid. When patients just continue to take the corticosteroid medication from the outside source, then his body stopped producing the adrenal hormone from inside, and it just rely on the outside source. So when in a period of stress, we will need more amount of adrenaline, right? So if that is not cop up, that's the reason when most of the complications may occur. So we need to calculate all those benefits and risk and what modification we may need to do. The doses and duration of treatment likely to cause clinically relevant adrenocortical suppression is not clear and varies significantly between patients. So, in which patient there is a risk of having adrenal consequences is the if any patient is taking oral prednisolone, which is at a dose of 10 milligram or more daily, or any other equivalent dose for more than 3 weeks. So there are three things, right? Oral prednisolone drug that is taken of a dose of 10 milligram or more daily for more than 3 weeks could be expected to cause adrenocortical suppression. A high dose of inhaled topical or intraarticular corticosteroids can also cause the suppression. So, patients with the adrenocortical suppression or adrenal insufficiency are at risk of glucocorticoid deficiency during period of physiological stress. What would be the period of physiological stress? If you are going to perform any extraction or any other surgical procedure that would lead the body to face the physiological sources, in that case there is a risk of adrenal insufficiency. Since the usual response of increased adrenocorticosteroid production will not occur because their body have now relied on the outside source only, so this can precipitate adrenal crisis. The primary manifestation, what are the signs and symptoms of adrenal crisis? There would be GIT symptoms and the symptoms of acute circulatory failure, which means hypotension or confusion. Okay, so patients undergoing a dental procedure may require an increased dose of corticosteroid because for the dental procedure, if we are going on, so that would increase the physiological stress in the patient's body. To cope with that stress, patient would need additional dose for the recommended approach for different types of oral and dental procedures. So perform dental treatment in the morning so that if an adrenal crisis occurs, symptom will present while the patient is awake. And after the dental treatment, ensure that the patient would remain in a care of a responsible adult for rest of the day, and the carer remains in contact with the patient for following 2 to 3 days. Advise the patient and the carer to seek urgent medical attention if the patient experiences symptoms of adrenal insufficiency, which could be those symptoms either GIT related symptoms or the acute circulatory failure symptoms. Then corticosteroid dose adjustment for oral or dental procedure. For non-invasive dental procedure, for example, if you are just doing the checkup today or you are going to take the x-rays or impressions, then do you need to modify the corticosteroid dose? No, there is no need to modify or increase in patients at risk, and advise patient to take their usual dose on the day of treatment. There is no need to modify their dose. But if you are going to perform the invasive treatment which will last less than 1 hour in an outpatient setting means in your clinic, inpatient means in hospital. So what could be the example of these invasive procedure? Like if you're going to do the scaling or cleaning, you are going to do the filling, extraction, periodontal treatment, implant placement. In that case, patient is at risk of adrenocortical cortical suppression. So for that, you may need to increase the dose of the corticosteroid. But as we know that we have not prescribed the patient this medication, right? So we are nobody to do the modification. So we need to talk to his medical practitioner, and he would be the best person to modify his dose. And most of those patients does have the dosing strategy or the action plan for the periods of stress. If they do not have, then consult with their medical practitioner, and the increased dose is usually started on the morning of the procedure. Okay, but if there is any invasive dental procedure that would require longer than 1 hour, or dental procedure that would require sedation, GA, or fasting, so you won't be treating that patient, you need to seek specialist advice on that. Okay, so generally in scenario they ask this middle thing, which these are the common procedure that you would be doing in your patient. So you need to understand that in this case you need to consult with their medical practitioner to ask if there is any how to modify their dose to make their body susceptible or compatible for the physiological stress. Then the very important topic again, which is the medication related osteonecrosis of the jaw, also known as MRONJ. Okay, so it is an area of exposed bone in the jaw persisting for when you have taken the tooth out and the socket is there and the socket has not healed, and it is the time which is like even after more than 8 weeks in a patient who are currently or previously treated with an anti-resorptive or angiogenic drugs. Okay, so who has not received any radiation therapy? If there is any radiation therapy, then it would be radiation related osteonecrosis of the jaw, not medication. So we are studying here the topic medication. So we will be talking about anti-resorptive drugs or anti-angiogenic drugs, which are mainly used for cancer treatment or any other cancer related non-oncogenic treatment. Okay. So the anti-resorptive drugs include bisphosphonates and denosumab, and anti-angiogenic drugs include bevacizumab and sunitinib. Okay, they interfere with the formation of new blood vessels and are used in the treatment of some malignancy. So we will be reading that here. Then, so this is some data that they have given. So osteonecrosis of the jaw is an uncommon adverse effect of anti-resorptive drugs, and severe cases have mainly occurred in patients who had dental surgery during treatment with the high dose of IV bisphosphonate for multiple myeloma or metastatic cancer. For example, if the patient has cancer or multiple myeloma, they would be taking high doses of IV bisphosphonate. If you do any treatment in that period, that would lead to MRONJ cases. Current data in oncology population suggests that this incidence of MRONJ of the jaw is up to 1 2, like these are the units, like 12,222 per 100,000 patients per year for patients who are taking bisphosphonate. For denosumab it is 2,316 cases, and for the osteoporosis, if the patient is taking their drug, then the incidence is 150 one sorry, I'm sorry. So based on the limited data, the incidence of medication related osteonecrosis of the jaw in patient taking anti-resorptive drug for osteoporosis, yeah, that's right. So for osteoporosis it is 150 per 100,000 patients per year, which is slightly only higher than in the general population. So for the patient who has osteoporosis, there is a risk which is bit higher than the general population, which is 150 cases per 100,000 patients. For the denosumab it is 2,316, and for the bisphosphonate it is at the higher level, which is the 12,222. Then there would be certain stages of the osteonecrosis, how it would occur in the jaw. So stage 0 would be when the patient would feel the pain and you cannot see anything on the radiograph, not even you can see anything clinically. So patient would only complain of pain. There is nothing that you can see on x-ray, there is nothing that you can see clinically. Then would come the stage 1, in which the patient would not feel pain now, but you can see the exposed bone, but there would be no inflammation or infection. And for stage 0 and stage 1, they only require follow-ups and monitoring, but no treatment. But if the stage 2 or stage 3, so stage 2 would include the pain, exposed bone, and adjacent soft tissue inflammation or secondary infection as well. In the stage 3, it would be painful, full thickness bone involvement, pathological fractures, extensive soft tissue infections, and fistulas. Okay, then you need to do the risk assessment for the patient. Either they have the higher risk or the lower risk. Bone invasive dental procedure, which are tooth extraction, any surgical extraction, implant placement, periapical or radicular surgery, periodontal flap surgery, they can trigger medication related osteonecrosis of the jaw. However, MRONJ can occur in patients who have not had a bone invasive dental procedure, such as patients with poorly fitting dentures or exostosis, which means tori or myelohydrid. So it is not definite that only the patient who had any invasive dental procedure they are at the risk of getting this MRONJ. But even if the patient has ill-fitting denture or any exostosis, they can also get this condition. Osteonecrosis that is not related to medication use can also occur at these sites spontaneously. Then what you need to do, you need to take thorough medical history, medication history, and dental history, informs risk assessment for medication related osteonecrosis of the jaw. Consider consulting the patient's medical practitioner, and you also need you are not only person who will make the judgment if the patient is compatible to do undergo any dental treatment or not. You need to consult with their medical practitioner. The risk of medication related osteonecrosis of the jaw is higher for longer duration. The risk would increase with the higher dose and high with the longer dose and the high dose, right? So the longer the time, the higher the dose, the risk would increase, and may be higher when anti-resorptive and antiogenic drugs are used concomitantly. So additional risk factor could be if with the female gender and with the increasing age, mostly older than 65 years. Okay, then there was a this test, which is the CTX test, which they used to do before to understand the level of bone resorption and the risk of MRONJ in a patient. But now they have published that there is an insufficient evidence to support a threshold serum to support this test, and this test can also get alterated by furthermore other risk variables, for example including patient age, gender, medical condition, menopausal status, any other drugs the patient might be taking, or the assay method used. So that's the reason now they are not relying on this test. Now they only rely on medication history and the dental history, which we will read in this figure here just in few minutes. Okay, so first we need to start with the history. So history taking to assess the risk of medication related necrosis of the jaw. First you need to find out if the patient has ever received any treatment for any bone or calcium disorders or any malignancy. Okay, so you need to ask the patient this question: have you ever got any treatment for any bone related cause or any calcium deficiencies or malignancy? So, what could be the conditions that might be treated with these drugs? Osteoporosis, Paget's disease of the bone, cancer, and the multiple myelomas. Then, is the patient currently receiving or have they previously received treatment with an anti-resorptive drugs? Which are the anti-resorptive drugs? That are alendronate, then denosumab, and all these drugs, which they can give you in scenario the patient is taking denosumab or alendronate, and they will make the medical history either daily, once weekly, or once monthly, and or can be administered IV and given less frequently. So these doses does depend on the risk of their cause, like whether they have the osteoporosis or any cancer. Obviously if the patient has cancer, then he would require higher doses and for the more frequently doses as compared to the osteoporosis, so they do vary. So you need to inquire about these things. Then, has the patient ever received an anti-angiogenic drug? So here we were talking about anti-resorptive drug, now the anti-angiogenic drug for the management of cancer. Which were the anti-angiogenic drug? These two. Then, if the patient has received uh, any of the above treatment, like whether anti-resorptive drug or any treatment for the bone or calcium disorder or malignancy or the anti-angiogenic drug, then you need to do this risk assessment with the patient. First, you need to ask him, has the patient been diagnosed with the MRONJ in the past? Has he had any past history? If he has past history is yes, then he would directly go into higher risk. But if it is no, then you need to find out if the patient has ever received this drug for the management of cancer. If he says yes, then as we read in those strategic data that there is a higher risk in patients who are taking for the cancer, then he would directly go into the higher risk. But if he hasn't received any treatment for cancer related cause, then there is still not a high risk. Then you need to find out if he had taken these type of drugs, like for example bisphosphonate, for a non cancer indication. If he says yes, then you need to find out the duration of bisphosphonate. If he says that I have taken the bisphosphonate for 4 years or more than that, then he would be in a higher risk. But if it is less than 4 years, and if the patient has not taken the bisphosphonate but has taken denosumab, then there are additional risk factors that you need to consider. Which are those additional risk factors? You need to consider how is his immunity, like whether he's taking any other drug or what is his immunity level. Then diabetes, anemia, hyperthyroidism, renal dialysis, glucocorticoid therapy, it means the corticosteroids, tobacco use, periodontal disease, denture use, or any local suppression. If any of these risk factor is present, then he would go into higher risk. Otherwise, he has if no there is no additional risk factor, he has just taken the medication, then he is in the lower risk, and the dentist can proceed with the bone invasive procedure, which are the extraction or whatever the your management plan is. You can go ahead, but this is very very important line, or the points you need to remember these things, that what additional risk factor can vary your management, which is you need to understand their immune compromise, corticosteroid therapy, then diabetes, smoking, anemia, hyperthyroidism, renal dialysis, periodontal disease, denture use, or local suppuration. Then how you can prevent a medication related necrosis in of the jaw. The most important point is maintaining optimal oral health and the precautions that you need to take while you will undergo the dental procedure. So how you can maintain their good health? Ensuring optimal oral health by implementing early dental assessment and initiation of appropriate dental care reduces the incidence. So early dental assessment and dental care is important. If a medical practitioner refers a patient for dental, because before starting this medication, medical practitioner generally refer the patient to the dentist to get their teeth treatment done, because otherwise there would be more complications. So in that appointment, dentist should undertake a comprehensive oral examination including pulp tests and the radiographs. The dentist should ensure that the patient is dentally fit and unlikely to require any extractions in the foreseeable future. The dentist should eliminate dental caries, which means like either he would do the restorations or extractions or root canal, whatever the treatment he recommend, he can perform that treatment on those visits, like before starting the medication, because once the medication would start, then there would be more chances of the complications. Establish a healthy periodontium, etc. Example, debridements or extraction, and encourage them to maintain a good oral hygiene. If possible, any necessary dental treatment should be completed before or shortly after starting the anti-resorptive therapy for osteoporosis, that is within 6 months. So, for the patient who has osteoporosis and they have started the anti-resorptive therapy, then you need to complete their dental treatment as soon as possible, within 6 months, first 6 months only. The risk of MRONJ of the jaw in patient with osteoporosis remains low in the early stage of treatment. Patients with cancer who are prescribed high doses of anti-resorptive drugs are greater risk of MRONJ, so ideally dental procedures should be completed before starting treatment. So here they just want to say that for the osteoporosis, as we read in those data, that it has lesser risk as compared to others. So we still have a leeway of 6 months that you can try to complete all the treatment within first 6 months of the doses, or the starting of the doses. Okay, but for the cancer, as the patient would be taking high doses of IV treatment, then ideally it should be best done before starting the treatment. And regular dental review is essential to monitor the oral health, which is the example clinical oral examinations and radiographs, particularly if the patient has a history of periodontal disease. Okay, so because we read here that the periodontal disease is also one of the risk factors, so you need to do the regular checkups and cleans, and advise the patient to seek early management of oral or dental related symptoms if one, and ensure optimal fit of denture, because we read here if the denture is not fitting properly, then it could lead to MRONJ. Okay, then effective communication between treating dentist and the medical practitioner is essential. Inform and involve the patient in treatment decisions. Precautions for patients undergoing bone invasive dental treatment. What precautions you can take? Okay, so careful consideration in patients at risk of MRONJ. Assess the risk and benefit of the dental procedure and the patient's risk of medication related. Like, what is the risk in patient of getting the MRONJ and what is the risk and benefit of the dental procedure? You need to weigh them, and this require a thorough medical history. For the patient at high risk of osteonecrosis, you need to seek expert advice and refer the patient to appropriate surgical specialists. But if the patient has lower risk, you can undergo the dental treatment in general dental practice. So what you need to do, you need to inform the patient of the risk of MRONJ and take the consent for the procedure. You need to see the advice on the drug holiday. We will read in next page. And scheduling of the procedure. Do not use antibiotic prophylaxis because that would not really help in the prevention of MRONJ. However, if there is any active infection, then you need to treat it accordingly. You need to ensure that your patient would maintain the good oral hygiene before and after the procedure, because we want the area to heal as quickly as possible. Reduce the plaque load by with mechanical debridement and pre and post procedural chlorhexidine mouthwash. That would help in removing the plaque load and would help in good healing. Try to minimize trauma and periosteum stripping during the treatment, during the extraction, and also place sutures. Monitor the oral wound until it heals. So you need to review your patient until his socket starts to get healed. Healing may be slow, but do not debride the non-healing wound. If there is any like the still you can see the bone and the healing has not occurred even after 8 weeks, then you need to refer the patient to the specialist. So, what the advice they have given about the drug holidays and scheduling of the procedure? If you need to perform any bone invasive dental procedure, which cannot be avoided because but it's not urgent. Okay, but it's not urgent to do the treatment today, like to pull the tooth out today, but temporary discontinuation of anti-resorptive therapy or timing the procedure to coincide with the low serum drug concentration have been suggested, but this is not really used now because they said that these drugs, these anti-resorptive therapy drugs like the bisphosphonate, they have very longer half-life. Even if the patient stop taking the medication for 2 days or 3 days by doing the drug holidays, still there is a amount of drug that is in their blood. So there is not really a good evidence to support this practice of the drug holiday. So the recommendation in international guidelines are inconsistent and vary depending on the indication for anti-resorptive drugs, the duration of therapy, and the presence of additional risk factors. So you need to use your clinical judgment of treating doctors, and the dentist is required to determine the appropriate management of each patient. The decision to alter anti-resorptive therapy lies with the practitioner who are managing their anti-resorptive drug. So you would not be doing anything. You just need to consult with their with their medical practitioner, and he would be the person who can modify if he thinks so. Okay, so for patient receiving anti-resorptive drugs for osteoporosis, the benefits of continued therapy outweighs the lower risk of MRONJ. So if you stop the bisphosphonate for a shorter period, is unlikely to cause harm in a patient at low risk of fracture. There is no evidence that this approach reduces the risk of MRONJ. So there is no good evidence that support that if the patient stop taking this drug for a shorter period of time, that then it would decreases the chances of getting him MRONJ. So the denosumab is a reversible anti-resorptive administered every 6 months for the osteoporosis. If it is possible to delay a bone invasive dental treatment in a patient taking denosumab, ideally schedule the procedure just before the next dose. So if it is next just before the next dose means, so if the patient has taken any dose, for example in January, okay, so first dose was in January, so because he need to take the another dose in June, so you need to schedule the treatment around end of the May. So in that period there would be lower level of this drug in patient's body, and there would be uneventful healing. So you need to weigh the, if it is not urgent, but if it is an urgent treatment needed, then you do not really have any choice, yet then you need to consult with their medical practitioner. Okay, so it is never appropriate to interrupt or delay the dose of denosumab. Withdrawal of denosumab has been associated with an increased risk of spontaneous vertebral fracture. So you should not be allowing your patient to delay that treatment, which is planned to be 6 monthly. You can schedule your treatment plan accordingly. And for the patients with the cancer, specialists would be managing them. You have as a general dentist, you cannot do much for them. So you would only be treating for the patients who are on osteoporosis. So schedule your procedure according to that. Okay, so this is also very, very important topic, and you will get one scenario from this topic for sure, like 100%. So be more thorough and understand if there is in any scenario, if they will give you any points, what you need to do and how you can manage the patient in a better way. Thank you so much, guys, for watching my videos, and hope to see you guys again in the next one. Thank you.